The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk.
Okay, everyone, welcome back to another episode of the Success in Practice podcast. Today, I'm rejoined for another round of podcasting with Matthew Harris. I'm here with Matthew Harris. Matt is a osteopath currently operating and practicing at Everything's Connected Progressive Osteopathy in Melbourne, Victoria. He's been a registered osteopath since 2004, having first completed a diploma in remedial therapy, then attending and graduating from VU, Victoria University, in 2003. Early in his career, he was able to travel and teach in the UK at the British School of Osteopathy. That's since had some problems that we may talk about. He eventually met Gary Gray, who had an impact on his biomechanical understanding. He attended a course with Gary at the Gray Institute in the US, where he learned about functional movement. Matt also studied classical osteopathy while in the UK, and upon his return, he combined his knowledge to help patients with their conditions. That's the knowledge of osteopathy, and I'm assuming through Gary Gray. He currently works in private practice and is a clinic, or was a clinic tutor for half a day per week at VU. And is also an athletics coach. As I understand, he's since ceased that role due to some scheduling conflicts at Victoria University. Matt, welcome to the podcast.
Hey, Sammy, how you doing?
I want to, before I go into any questions, mate, it's very refreshing having you, and me being able to see you very clearly and hear you very clearly. Matt was one of the first episodes that I recorded, and we had some technical difficulties with I think it was Google Meet or Zoom or something that we did it on. And now, thankfully, we're on a better platform, and Matt has invested in a better laptop. Right. We get to see Matt. He's much better looking this time than he was the last time.
Probably not. I look better hazy.
Well, we'll see what we can do post production, mate. Anyway, I guess I want to talk about. I want to recap some of the things that we spoke about last time, but we'll get to that. Last time we spoke, you were in private practice and doing some teaching at VU. I first want to just ask you about your private practice. In the last 12 months since we spoke, has anything changed for you? Has anything happened you want to share with us? Anything you've learned that's new? Anything you've been working on? Anything that's intrigued you or taking your practice in maybe not a new direction, but maybe a little rabbit hole that you want to share with us? Something that might offer the viewers or the listeners some insight into what an osteopath might go through over 12 months.
Yeah, well, it's been a pretty busy 12 months for my clinic in general. I got taken away from, well, not taken away from the clinic, but taken away from the uni because I was working with the Victorian women's lacrosse, and the hours that I had to put into that just meant I couldn't do the uni as well. But then also we were a really tight little family, my clinic, and we had some troubles this year in terms of just health of some of our practitioners. And so that meant a lot more, gathering around and support and digging in a little bit harder each individually and that sort of stuff to pick up the load and help people out.
I understand that.
Yeah. And so that was a tough year, but we've gotten through it, and looking forward to the end of the year, just having a little break. So that'll be nice as well.
You'll have a stronger team because of it.
Yeah, look, I've got a wonderful team where my guys they're there all the time. They're like they're cool kids. They're a lot of them actually just, when things get stressful, just come down to hang in the clinic, just because it's a place where they can,
So tell us for them. Who's working with you at the moment, not who, but like how many practitioners, what have you got going on?
Myself and 3 others.
3 other osteopaths.
Yeah.
Right. When was the last time you had to hire an osteopath, Matt?
Well, so T is my youngest osteopath, and she's 5 years out now.
Right. Okay. And you didn't have much trouble, I guess, getting applications through? Was that pretty
so if I'm
process for you?
So my clinic is quite specialized in terms of the AFS model. So the guys that come into it, basically they're all trained with the Gray Institute. So that's it's always slightly difficult when you have running a slightly different process, I suppose. Yeah. So, and look, to be honest with you as well, like I feel like I've been in a lot of clinics over time, and this is not my first clinic. I had a clinic in London with some friends.
Yeah.
And I've grown a lot of practitioners in my time, but I feel as if I'm getting tired.
Mm.
And it's harder for me to grow a practitioner now. Does that
Yeah,
make sense?
right.
Yeah. I think as well as the gap gets bigger and my knowledge gets greater, the gap between myself and a young practitioner is a little bit harder to fill, if that makes sense.
Yeah, there's a bit of fatigue there by the sounds of it.
Yeah, well, there's look, my guys are great and that sort of stuff, but like, I mean, I love practice. That's one of the biggest problems I've got. And so I'm not very good at, handing off patients. I like patients. I want to see patients. I love the job. And so that's I guess my first love. How's that sound? My second love would be mentoring, but because I do enjoy that, but it's like really, I just want to be continually getting better. So, I go through periods where I go through more education or less education myself, if that makes sense.
Yeah.
Yeah.
That's not an uncommon thing. I share your experience in terms of, trying to get people upskilled to a level that, and it's not even just a basic level. You want them a little bit better than basic. I mean, if you really respect what you do in the clinic, you don't want entry level. You want a little bit better than you can kind of get that, but that takes time and energy and love. You gotta put your heart and soul into it. And especially if you have a family, it means you got to take time away from that. It's extra time out of the clinic. You don't get paid for it. There's a win on the end of it. Obviously, when you see the practitioner improve and do well, but that may not be for a little while, just because of the nature of things and the nature of the market the way it is, and it gets harder and harder to wait that out.
To start to perform better than you, I think there's nothing better than that. Like that is really like that's when I look at some of my older practitioners, they're doing stuff. I'm like, oh gosh, wish I'd have thought of that. And that's a really nice feeling. But like you said, to get to that point, it's a lot of there's a lot of effort put in by yourself and by them.
Yeah. It can be a little bit fatiguing, and as you get on as a practitioner, you just want to go back to your basics and just do what you love. And it's not that you want to stop mentoring. It's just that you want to just have a break and kind of like just do what you like. Clinical stuff almost seems like it's on autopilot after a while. And other things in your life come in. You got a family, you got young kids, you want to go watch your son or your daughter play sport, you want to spend time with your missus, you want to go on a holiday. These things you've earned. And then, whenever you've got to kind of retrain somebody, it takes away from the time doing that. And that becomes a very acute thing that you're aware of as you get on as a practitioner. So I totally feel where you're coming from. Definitely.
Yeah, absolutely. This funny thing, I do have an Oura ring, funny chance.
I don't, but I've heard of them. Yeah.
What's quite interesting, it's supposed to be measuring your stress levels and all that sort of stuff through your temperature through the day. And I'm at my most relaxed when I'm practicing.
Yeah, wow.
Like it literally says something. Yeah.
No, I wanted to get one. I just can't wear anything when I'm sleeping.
Yeah, right.
I can't wear anything like watches or bracelets or rings. But even when I'm practicing, it's hard for me to, even my wedding ring, I tend to wear it around my neck, but it's hard because you do a little cuddle technique and you get your hand in there and it's just crunches. So it gets a little bit difficult. But yeah, no, I get where you're coming from. Only the least stressful part of my job is treating.
Yeah.
Dealing with employees, dealing with other practitioners, dealing with some of the other providers, I guess, whether it's insurance companies or GPs or whatever. Those things take a little bit more stress out of you than treating's easy. It's not difficult.
Agreed. And the business side of it as well, that's just hectic, which is something I like. Another reason I could never have a big practice. I just can't. I can barely manage a small practice, let alone like when I think about all the great stuff that Jade does, I'm like, oh my God, how could you ever do that? Like with her whole osteopathic empire she's built. It's so phenomenal.
Like you don't build that in a short amount of time. You kind of like you stress up to it, I guess. You stress a little bit and get used to it and stress a little bit more. But I guess also though, it's really hard. One thing I've noticed, and I've seen a lot of the business side of things and the clinical side of things, I think it's very difficult to be a really good clinician and a really good business person. And I'm not talking about somebody, excuse me, I'm not talking about somebody that just runs the business and treats and, has a couple of practitioners there. I'm talking about, a real kind of like someone that's all over marketing, all over the providers and all over the employees and all over the front end staff, the systems, the operations, really constantly. I know of a couple of people here that do that. in Sydney. Obviously, you mentioned Jade up in Melbourne. I would assume they'd find it very difficult to be practicing, seeing 60 a week and, or 80 a week or whatever it is, and still do that. That's not going to be a feasible thing. And so whilst if the listeners are paying attention, don't think that you have to be able to do that. It's usually one or the other. One thing I do want to ask you on that as a little segue is that I heard someone say that, to run a practice, I guess, and not be under a bit of stress from the business side of things, you've either got to go big or go home, which means you've either got to have, 7, 8, 9 practitioners running in the way that I just described, or you've got to, just 1 or 2 practitioners. The middle ground is not a really feasible business model just because it takes a lot out of you and doesn't give you much back. And you only really start making a really good income after you have your 3rd or 4th or 5th practitioner. How do you feel about that statement?
Well, I feel like that fits for my practice. Like
What they're saying is that living in that middle ground is highly stressful.
yeah. So like if I was talking about my practice, so there's the 4 of us, we do a lot of co-treating together. We do a lot of mentoring with each other. Like this afternoon, I was with 2 of my staff members and we spent 3 hours going through difficult cases and discussing ideas. And that's something we do all the time. And I would prefer to invest my time in that and making them better than trying to get my Google ads up.
Right.
Like it's not like,
I
so I just couldn't see myself ever being able to do that side of things, if that makes sense.
Yeah, definitely. That makes sense. Again, like I said, it's to get to that level, you've got to be on top of all that stuff. And I guess you build systems around it, which takes a lot of the stress off you. But I tend to agree with the whole middle ground thing. I think if you're in the middle ground, it's a lot more stressful than either, just being either a solo practitioner where you have yourself and a receptionist, or 1 other practitioner, and then, or you go big and you go 10 practitioners and big rooms, big clinics, physios, chiros, osteos, speech pathologists, the whole thing. So yeah, but I think I think we're starting to see a bit of romanticism around larger clinics where I want to kind of bring people back and say that there's a lot of value in having a smaller clinic.
Absolutely.
There's so much value in it and you can make really good money, you can make good income, and it's not as stressful as people think it is if you find the right team and you get a good receptionist around you. And I guess you time manage yourself really well. So there is that too. So yeah, definitely I think people should neglect the smaller clinics.
Yeah, no, I think in the smaller clinics as well, you can really build, osteopathy is, if you're doing it well and really caring, it is mentally draining. And having a small group around you that's prepared to support you. Often, so my team, we will pick up that one of us having a problem before the person knows they've got a problem. You just start to see them get flat and and you can support them very well. And I'm sure the big companies can do that, have systems in place for that. But it's a little bit different when when you're so tight knit, I think.
Yeah, no, it's like listening to a song on a record player versus listening to a MP3. It just sounds different. It does if you know what you're listening to. All right, so I want to shift a little bit here. We talked about your private practice and what you've been doing now and some of the challenges there. Let's talk about, I guess, your time at from what I understand, the last time we had a conversation, I guess we discussed some things to do with how you thought osteopathic education was becoming a little bit diluted at the university level. I've had multiple people on this podcast since we had that conversation who have all echoed your statements. And I think the majority of the guests that I've had, and I don't know if that's a product of selection. I don't think I'm selecting them that way. I'm just asking people to come on and have a chat. Most people agree that the level of osteopathy, and you can take that for whatever that means, but we'll define that in a minute. It's the graduates coming out have a lesser, it's a diluted, we're seeing it diluted. And if a young practitioner is somewhat inclined to think from an osteopathic, philosophical, classical point of view, they've really clung on to it. They've had to really be passionate about it and go looking for it, which is great. And I think everybody should be doing that anyway. Do you, I guess, still share some of the things that you discussed last time? Do you still think that there's a bit of a dilution there and it may not be just at VU. I mean, you're seeing other graduates too, but based on your time at Victoria University and I guess based on what you're seeing in private practice and some of the people that you're seeing out there, do you still feel that there's a dilution of osteopathy, in classical osteopathy in the graduates that we're seeing? And that's not to blame the graduates. We'll get to that. Yeah.
I think that I can't talk for VU because I haven't been in there. Like I haven't been in there for maybe 6 months, 7
Okay.
months now. I know after we spoke last time, I know I offended some people, which I wasn't meaning to offend,
Some
which
staff.
some staff that
Right.
wasn't my intention. So I apologize for being offensive, or if they found me offensive.
No, I don't think you were offensive. I don't think you said any personal attacks on anyone from memory.
Well, I wasn't
Listen to
meaning
that.
to. That was not my intention. But what so I will say that Gary and I had some good conversations afterwards, and
Right.
some things we were on the plan to be implemented. It, like he did tell me that history and principles would go back into clinic, and
Right.
he has said to me that perhaps he will rejoin the clinic. And I don't know if those things have happened or not, but I do know that. So there was some fruitful things that came out of it, even if the intent came across wrong.
Well, I think the intent was right, but the message gets
The
received.
message.
It's like if you talk to 5 people, it's hard for someone to be offended. But if you're talking to 100 or 1,000, you're bound to have somebody to get their noses out of joint.
Yeah, that's true. That's true.
So it's just a matter of, do you then restrict speech? I don't think you do. I think you know what you feel and your opinion needs to be shared. And I think we also have a problem in the profession of people getting their noses out of joint. We can we not have a conversation about this? And I was able to talk to Gary. I'm going to echo what you just said, because I was able to have a chat to Gary on the sidelines of the conference, the osteopathy conference back in Sydney last year, and he said the same thing that you just said. He said he heard what was said, and he's taken it on board, and he wants to bring back some of the more principled osteopathy into the course. So I too hope that that's happened, and I am having a chat to Gary. It will be another episode happening very soon with him, and so I'll ask him that question. I'll see what's happening. But in saying that, I mean, it's you, mate. I've listened to that episode. You didn't offend anybody. You didn't name anybody. And people need to understand they take on a role, they take on a job at university, that they're responsible for the education of students who end up being practitioners that we have to deal with as clinicians in our practices. And if we see a gap in that education, it's best that we call it out. We're making your job easier. At least you know what's happening. If you got your head in the sand and going, oh, everything's great, then that's not good. And I will go a little bit further in saying that I've never met a clinician, an actual osteopathic clinician, that has said to me that they've been offended about anything that's been on this podcast. I have heard from some academics, not all academics, that they don't like some of the things that were said. So I don't know what it is about people doing PhDs or people doing research or whatever it is, or people just who are teaching, but they seem to think that we're attacking them personally. I'm not attacking them personally. I'm not attacking the effort even. I'm sure they put in a great effort into what they do, but I think we have every right to critique the outcome, and that's something that needs to be said. And I guess if anyone wants to have a chat to me about that, the platform is yours. Come on the podcast. Let's have a chat. Let's have a debate. And you can tell me how wrong I am, or you can tell me what your views are, and I'm happy to go back and forth. I'm not going to get offended. I've been offended. If I'm going to, and this is why I think clinicians don't get offended so well, because a lot of the times we cop that from patients and we get used to it, Patients will tell us, I'm not getting better, or something's happened or whatever. And you can't just blame the patient. You've got to take it on board, make the adjustment, change what you do, figure out a way. But, if somebody who's teaching gets offended because people in practice are saying that the outcome of the students isn't to our liking or to the standard that we expect, you can't blame the profession in saying that. You can't blame the professionals. You need to look inwards first, and see what's happening. Are we teaching the correct things? Are we teaching them in the best way? Are we creating an environment where osteopaths feel passion for osteopathy? Are we telling anecdotes about clinical things? This is where I found my passion for it. I'd listen to my mentors tell us anecdotes about some of the great results they got in the clinic, and it made me very passionate about it. I had Bruce Lang on the not Bruce Lang, sorry. Oh geez, I got a mind block. Bruce Duncan on the podcast a little while ago, and he gave me an anecdote about some of the joy he got out of the clinic treating one of his patients, and I love hearing that stuff. It just makes me passionate about osteopathy. So, are we doing that? Do we have people in? Do we have teachers who are do they have real world experience teaching what they teach, and they can go into a clinic and say, this is a technique we're learning today. And hey, by the way, I had a patient who came and saw me 3 or 4 years ago, and through doing X, Y, Z, we were able to improve da, 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 da. And isn't this amazing? But you need people with experience. You can't have people, for example, let's take manipulation, as an example. You can't have people who barely have practiced 10 or 20 hours a week for 4 or 5 years, go into a university and then teach manipulation and think that that's okay. If you're doing that, you've done that, and you don't practice using manipulative techniques day in, day out, you'd have no business teaching that subject. And you can extrapolate that to muscle energy technique, counter strain, functional technique, cranial, if that's the way you want to go, exercise, rehab, whatever it is, whatever subject that you're learning, if you don't do it, or not subject, sorry, but whatever technique you're learning, if the person who's teaching you isn't doing it day in and day out, they have no business teaching you. And so, that might be a gap. That might be something the universities need to look at, or the heads of universities need to look at. And so in saying that, people get their noses out of joint, but really I think a bit of introspection needs to happen first before we start laying the blame elsewhere. Sorry, I've ranted a little bit, but I'm going to let you chime in.
No, I think that's good. I think within the uni, there's obviously constraints that I think what's interesting is like I'm in private practice, and my skill set is around private practice. So I'm doing it day in and day out. I've worked hard on my osteopathic skill level. The ecology within a university is a little bit different because I guess it's a case of knowledge of versus knowledge in.
Mm.
Yeah.
Yeah.
And I think that when we have an education process that either goes too much knowledge of or too much knowledge in, you end up with a bit of a problem. Does that make sense? There has to be that balance with, and so that's what I would hope that the university would strive towards. And part of that for me would be because I'm a clinician, I went into the clinic. I'm not lecturing. I'm working as a clinician, showing the thing that I do. Having an academic in the room with me that can lay the foundations of some of the science behind what I'm doing is fantastic. Yeah, but and there will be slight discussions and arguments between the two professionals if things are going well, because you never see eye to eye, and there are there's always some of the old osteopathic techniques we romanticize over, and we need these academics in there saying, hang on a minute, that's not quite what's going on. Doesn't mean it's not having an effect, but it might not be having the effect that we think it is having. Does that make sense?
Yeah.
And so we really need this balance within the universities. And I feel like sometimes that balance can get out of whack a little bit. And like I said, after discussions with Gary, him saying he's coming back into clinic, getting I heard through the grapevine, I'm not 100% sure, but that John Pitcher might be coming back into the clinic. But for me, I'm like, that's exactly what should be happening. That's a win, so that students have the ability to learn and model.
Yeah, definitely.
Because I think that modeling is what you're talking about is an important part. Like if you're coming back to HVLA, if you're not used to manipulating a patient in acute pain, but you're in front of a student trying to demonstrate that on a patient in a room, that will be seen through straight away. Does it make sense?
Well, it may not be seen through by the students. They wouldn't know any better, but the outcome's going to be poor.
Well, this is what I mean. But it's the patient will. This is part of the things that make a good clinician is you've seen the problem enough times that it no longer. I won't say it no longer scares you, but you know how, you have more of an understanding how to work with it.
Yeah, it's not a problem anymore. It becomes something that you're able to go confidently assess and treat. You're right. I think, but also we need to also understand that if you take both sides of that, you said to have the knowledge in versus knowledge of, and you might have a practitioner that's quite confident in their skill set versus a practitioner who's well versed on the science. One thing I've learned is that the science tends to follow what we do rather than, be in front of it. So that's the first thing. The second thing is that the outcomes are really what's important. And even research is going that way. Research in our field is moving away from double-blinded randomized controlled trials to PROMs. And patient-reported outcome measures. And so for patient-reported outcome measures, we care about treatment because this is the essence of it. And so really in the real world, in the real practical world, the researcher has become somebody to validate what we're doing rather than to instruct or to lead the way. And I know it's hard. That's hard for people to hear, especially academics out there. It's hard for people to hear because I think they see themselves as, I guess, pioneering some kind of, and it's not totally incorrect that they're pioneering the research, but they're not. I don't think I don't think there's anything new under the sun. I had a conversation with Dr. Raymond Perrin recently, and that episode has since gone to air. And he was doing what he's been doing since 1993, and the research caught up to him.
Mm.
Had he listened to the people that were telling him that all of what you're doing is nonsense, we wouldn't have a very evidence-based approach to chronic fatigue syndrome, an osteopathic approach to chronic fatigue syndrome. And so we have to be really careful in who we present as like it's like most relationships, we'd love to think 50-50, but they're not. They're not democracies. They're generally, there's a hierarchy of values. There's always a hierarchy that develops, and the hierarchy needs to develop within osteopathy. And I think it's just gone askew a little bit. We're valuing the researcher. We're valuing the people that are doing things that that catch up to what the clinicians are doing. We should be talking to the clinicians and asking them what they need done, and the researchers should be following that. And you're right, there needs to be a bit more of a link between those two. And if there is, then that'll be great. I don't see that happening though, because I think they just butt heads too often.
Yeah, look, I don't know whether it can happen or not. I think ideally, like I said, I do feel as if that. So I do think that academics play a little bit more role than what you're saying, because there are times where there's things that we're doing in clinical practice that aren't perhaps as efficacious as we think they are. And they can quite successfully direct us into different directions. What I do see is a little bit of a problem in osteopathic research, and it's probably more to do because we don't have the funding or the facilities. But I would really love to see more research into the effects of manual medicine or like hands-on treatments and that sort of like. Obviously, at the moment, there's an undercurrent that would say that all the effects of hands-on manual therapy is due to what do they call it? Essentially, they're all neurological effects, basically, that we're seeing. The research doesn't indicate that we're getting real tissue change in terms of long-term. It's short-term effects and this, that, and the other. But what I would argue is that we haven't really put in enough of our own research to definitely say that that is the case of what's happening. Does that make sense? Like, if we talk about the Perrin technique and that sort of stuff, I mean, his whole theory is shifting lymphatic fluids. Yeah, that's basically, and cerebral spinal fluid, that sort of thing. Yeah.
Yeah, he's looking at lymphatic drainage of the brain and the cerebrospinal fluid into the lymphatics, and then obviously that affecting the sympathetic nervous system output and regulating fatigue.
Excellent. And they're all basic principles that we would have learned when we were doing osteopathy initially. It's one of the circulatory model was one of our founding models, that you would have covered.
Yeah.
And so, there's evidence is questionable about how much that actually creates change within our patient base. Does that make sense? And only because I think the research hasn't been done enough to actually establish what has happened. We have seen there is the beginning of research, especially in dogs and cats and that sort of stuff, to show that we actually can affect some of the cytokine processes that are happening in that early stage with our hands-on treatment. But it's early research, and because it's early research, it doesn't really count yet. Does that make sense? And who's going to do that research? The physios aren't as interested in the hands-on as the osteopaths are, yeah? Like I said, so I feel as if it would be lovely if this side of the world could get involved in that sort of academic study. And I guess, like I said, most likely it's because we don't have the finances or the resources within our universities to be actually to do that sort of thing. So then our research becomes, a lot of our PhDs are collations of meta-analyses of, does that make sense? Of what happens when we just HVT this and blah, blah, blah.
Yeah, no, I get it. I understand what you're saying. I think there's a problem also that, we're desperate for research, so we just take anything that even osteopaths, we kind of take any topic that osteopaths want to talk about. And so I think we need to be a little bit more scrutinous on the actual osteopathic approach to XYZ that you want to do research on. Is it osteopathy that you're presenting here, or is it just, exercise physiology.
That's what I think that's what's happening in the university, but that's not. I don't think that's the academics' fault. I think that's the difficulty of working in.
Yeah, I get it. No, I don't think it's the academics' fault. I think it's a profession's fault. Like the profession has to always take accountability for it as a profession. I know Osteopathy Australia have research grants, for example, and so they need to scrutinise who they give those research grants to and make sure that we're really validating osteopathy and not not any other, not to take away from physios and chiropractors and what they do, but especially exercise physiology. I think exercise physiology has a wealth of access to their own research material and funding, and many universities run those courses now. And so we really need to be focusing on the hands-on effects. And I think the shift towards proms is so encouraging, because that's really what we care about. When we talk about research and trying to, I guess, reduce the patient, down to standardize the patient, N equals 1, we really want to make sure that we can apply things to the patient right there on our table. And patient-reported outcome measures make sure that we're getting feedback from the patient that this is working. Is it placebo? Is the tissue actually changing? Is what I'm doing actually doing what I say it's doing? Okay, maybe not, but the reported outcome measures are great. Okay, well that's a great start. So I think it's really encouraging that research in our field is shifting towards proms. If that continues to go that way, it'll be great to see osteopaths, and if they're students, if they're PhD students, if they're master's students, and they have to do research, then it'll be good for them to start to apply osteopathy, osteopathic techniques, osteopathic approaches to certain conditions and look at proms. But to be able to do that, they have to know osteopathy. This is the problem, right? To do that, they have to know osteopathy. And I guess we can't throw the baby out with the bathwater in that sense.
I do think that, so, because I don't want to, so coming back again, it's fantastic that VU and RMIT are getting more and more PhDs, because it does put us in the it puts us in a different conversation with other health professionals. Yeah, because there is a real particular language that is used amongst the and one of the things that I'm a very proud osteopath. Not a part of me wants to be a physiotherapist. Yep. Not a part of me wants to be a chiropractor. I don't know if I'm allowed to say that sort of thing anymore or whatever, but yeah. So I like our principles, osteopathy, the way that I get to create my own artwork every day, the way I practice on my patients. And there's not many other therapies that allow you to be creative, because most aren't philosophically driven, where you can be artistic and skilled. Does that make like?
Yeah.
So one of the most beautiful things I think about osteopathy is that it is you highly attune your own skills, and because of that, and because you're following principles, none of us look the same. Now, I think that's an amazing thing. It's also one of our detriments. So a patient can come and see me, and I'm movement based. I'm still hands on, but then they go down the road and they see a cranial practitioner, and they lay on the table, and they have a whole other experience. But my philosophy is the same as their philosophy.
Yeah.
It's just the skill set that we've chosen to adapt to access that patient's needs is different. Yeah. And you don't get that in any other field. And that's the beauty of what we do. That creativity, that being able to put your own essence into it, that is a huge part, I think, of what osteopathy is.
Yeah. No, totally agree. And that should be reflected in the research.
And that's what I was going to say. And the academic and the what would be nice is if the academics that we have moving forward can see that beauty and actually work with it. But here's the thing, like I said, I'm going to say it again. When I watched them, listen to them talk and watch the way that they can analyze statistics and the way they think about setting up design, I couldn't do that. I don't want to do that. I want to be a clinician. So I think we do need specialized academics that enjoy that side of work in there pushing us forward. Now,
there are people like that.
I know there are. Like, because again, there are people like that in. Let me come back. Victoria University is full of people like that. That's not like, I'm not criticizing anyone. What is, I think that does happen within, because every ecosystem, like it's like in a clinic, right? So if you come into my clinic, we're all functional. We'll do AFS, functional practice. We talk the same, we move the same. It's all a little bit different to the cranial person down the road. That ecosystem builds a joint interest. Does that make sense? So Yeah. And I think the same things can happen in universities.
Hmm.
So, because I'm sure like the whole academic department are really close. Of course, they'd be really close. They'll be talking to each other about their ideas all the time. But then those ideas become more localized to the same thought
Well,
process.
they become policy as well. They can become policy.
That can
right?
happen, yes.
And so that's the issue, is that we don't want to see a disconnect between the academics who are shaping policy, and they are shaping policy because they're academics, they're there full time, and and to see that policy be a little bit antithetical to what a clinician's view on osteopathy, principled view on osteopathy may be. And so this is where I think the head of a course, the head of a program, someone like Gary Fryer, should be somebody who, and Gary is that person, who has real world experience in clinic and is also understanding of the clinic, of the university structure. And so this is a really fine balance. I totally get the fine balance that it takes to kind of run these courses. We're having this talk, we're having this debate, I guess, or this conversation so that people are aware of it and that they can talk about it, because we think that we don't want to leave people on their own. Like, you guys are researchers, academics, you do your thing and I'm here in the clinic doing my thing. Because what will happen is if you let that happen and you don't get involved as a clinician, you don't get involved as an osteopath in that conversation, you very quickly, you'll find that the course is not as because universities place pressures on courses to include subjects like, cultural studies and things that may seem quite arbitrary to what we do in the clinic. But to do that, they have to shoot something out. And they're not going to shoot out neurology and biology and pathophysiology and physiology. They're going to usually shoot out the philosophy and principles that we learn. So as a clinician, as somebody who's in private practice and you're there practicing, doing the right thing and kind of doing your thing, don't think that you can't or you shouldn't speak up about what's happening at universities. Because if we leave people who aren't, I guess, as experienced in clinical practice to run policy, you'll find very quickly that the outcome of the students that are coming out of the universities, they won't fit into your private practice. Well, not that they won't fit. It'll just be you'll get this fatigue that you talked about earlier, of trying to upskill people and getting them to a certain level. And in saying that, I want to make it very clear, I think there's some very good academics out there who have real world experience. I know there's Rosalba Courtney, who's done a lot of, has been an osteopath for over 40 years and done great areas in breath work, and she's a PhD person. Lainey Cameron up at SCU. We've got people, there's plenty of people out there.
Absolutely. I mean, Lainey Cameron's my mate. Like, yeah.
Yeah, they're people that have treated, they help people in clinic. They know what they're doing, and so we want them. They're gold. But yeah, we just need to make sure that if we don't throw the baby out with the bathwater, that we don't just put people in there that are, like I said, have been practicing for 3 or 4 years and, oh, you know what, clinical practice stuff, I'm just going to go straight into research. Take that for what you will. You want to get offended, that's fine. I don't think I don't know if that's going to be a healthy thing to have lots of those people shaping policy at a university.
Hello everyone, I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list, and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
But anyway, there's plenty we can talk about that. I'm sure we'll probably do a third episode. I guess then, from what I understand, mate, your time at VU was largely positive, and I'm kind of glad knowing, having talked to you, I'm kind of glad that we had that conversation, because I think some good things came out of it.
Oh, definitely. I think that's definitely true.
Gary's credit, he kind of talked to you face to face, and he had a chat to me face to face, and he had some great points that he made to me, and all credit to him for hopefully making those changes that he said he would make. But yeah, from what I understand, you're
Oh, look, I love the UVU.
positive.
I'll go I'm not in there at the moment, but I do want to go back. I think when I have time again, I'll go back and do more tutoring and that sort of stuff. And they haven't closed like that. The doors there aren't closed to me. I think that I think it's any clinician that has been practicing for a good period of time should go into the uni and try and do some clinic work, try and give back a little bit. That's important. And I also think, coming back to what you're talking about before, one of the biggest difficulties, I think, and this are probably a difficulty for both the OA as a board and for the academics in the universities, is that the clinicians out in the world don't turn up enough. Yeah. So I get it. Like, I don't want to teach full time. I wouldn't want to do a PhD. It's not something that interests me, at least not at this point in my life. But I think it is our responsibility as people practicing to get up and speak about the things we think we need, or the things that we think we see, and have conversations with different people like Gary when you can, to just get your point across, just to, and hear, Gary's, like, I've got nothing but really good things to say about Gary. Like, I went to I think I was telling you earlier, I went to the OA open, what do they call it? Town hall.
Yeah.
And Gary was there, and I said some things, and once again, he was very quick to come up to me and then ask, he wanted to know more about my opinion and discuss things that I was talking about. He's just like, we may not agree on things, but he's willing to discuss and to exchange ideas. And that's what we want.
And that's exactly what you want. And then somebody not to come with I guess, an attitude of, offense, like, I'm offended that you said that, we're all adults. Like, it's no one's saying anything offensive. It's just that we're allowed to have an opinion on these things. Just because we don't teach at the university, or we're not part of the staff, the products of the university are coming onto our staff.
Correct.
So, we want to have a conversation. And we need that conversation to be as rigorous as possible. So everybody needs to be able to put all their cards on the table without fear of being, complained against,
Yeah, agreed.
Look, I'll give an example. Like, I put up some posts on the member forum, the Osteopathy Australia member forum, and saying that, if you'd like to learn some more practical things that you may not see at university, attend this course or do this or whatever. And so that post got taken down because they said, some people called up and said that they were offended because they teach at universities. And understanding, if they're offended by it, or if they disagree with it, tell me that you disagree with it. Like, argue the point. Don't argue the person.
Yeah.
As soon as you start making complaints and shutting people down, I'm one of these people that will just go in harder, because I'm like, okay, you're shutting that down. There's something there. Like, and maybe there isn't something there. Maybe, like what Gary said, like he said to me on the sidelines of that OA conference, he said, Sami, it's not a conspiracy. We don't sit there and wonder how we're going to reduce osteopathy, and I believe him. I don't think that's the case. He said that, a lot of these things are available for students if they want to just chase it and follow it. But in saying that, we need to be able to have these conversations, say what we need to say, without fear of being complained against or called a bully or whatever you want to call it. Nobody's attacking anybody. Nobody's saying that you're bad teachers, but clearly there's an outcome problem with some students. A lot of practitioners I've talked to have said that. A lot of students, the former students who are now recent graduates, have said that. And so, okay, do we just sweep that under the rug and not talk about it? Or do we put it out there and talk about it? Okay. And so you've got some things to say, not yourself, but the people who are maybe offended about this have some things to say about it. So let's say it. Let's put it out on the table and talk about it. Gary was able to do that, and he did it really well. And he convinced me of some things, and I convinced him of some things. And so that's how shit gets done. That's what we want. We just want that kind of environment. I want to ask you, Matt, about, I guess, look, I've just touched on this in what I just said earlier, but there is, and this may not be a conspiratorial kind of thing that's happening. And you mentioned it before that, an ecosystem gets built where a certain type of education gets given. Do you fear, though, that there's a slippery slide towards, say, a monochrome type of therapist, one that, do you see some kind of Orwellian problem that we're going to have, in 20 years' time where we're not even registered as osteopaths, we're just all physical therapists? Is that something that worries you?
Yeah, it does worry me. I think that the evidence base is vast, and we can choose to use particular sections of it to frame our argument one way or the other. Or we can, so let's just, if we were to take throughout the history of different universities, we have our principles, but there's always a model running underneath the principles. Yep. So like at the moment, the biopsychosocial model would be running underneath the principles themselves. And in the past, there's been lots of different models. We've had, like, before, we had the 5 different osteopathic, you have the circulatory model, the respiratory model, the neurological model. They would be things that would have been learnt through Kuchera or Greenman, along those lines. So there's those things that are always happening. Now, at the moment with osteopathy, and it may be the majority of osteopaths, so I don't know, because I can only tell you how I feel. Yeah. But it seems like osteopaths aren't, come back to what I said earlier, a lot of osteopaths aren't happy being osteopaths. We want to compare ourselves to stuff all the time. Like you don't see on a physiotherapist's website how it differs from osteopathy. Yeah, but you see that on a lot of osteopathic websites. Yeah. Like, why?
Well, it's a common question, I think, from especially a lot of our patients.
Correct. But why is it a common question? It shouldn't be.
No,
somehow,
you're right.
Yep. Somehow we have to create a voice for what we are. Like, and we have to make a choice on the thing of what we are. Does that make sense?
Yeah.
Like, yeah. And it doesn't seem like we're doing that because, like I said, we get that question all the time. Does that make sense? Yeah.
Yeah, I agree with you. I'm going to cover that in a later question that I have for you.
Okay.
But yeah, definitely to, I guess, have some kind of counter argument to that whole monochrome therapist.
So this is what I was coming back. I guess this is what I'm coming back to.
I get your argument. I think what you're saying is that, to have that particular fight against that is you need to first define who you are, and then you need to maintain that, without first defining what you do and who you are. Then we are at the whim of the broad spectrum of evidence that government policymakers and things like that can kind of regulate us into.
Correct. We're at the mercy of these guidelines, like, the Canadian ankle guideline or whatever guidelines you want to do in, like, yep. And like, that's just, it's just not the way that I think osteopaths should be thinking.
Yeah.
Like,
okay.
Yeah. Or what I was taught to think. How's that sound?
I will ask you more about that in a later question. You said that you went to the Osteopathy Australia town hall that happened in Melbourne recently. Are you currently a member of Osteopathy Australia?
No,
Matt?
no, I'm not. No.
Why not?
So I am thinking about joining again.
Well, were you ever a member?
A long time ago, yeah.
Right.
Yeah.
What made you cease your membership?
So what happened when I left? I left and went overseas and practiced overseas for 10 years.
Right.
And then when I came back, so in the UK, osteopathy is very different. It has a lot of influences from a lot of other countries. It influences from like Italy, France. There's lots of different types of osteopathy. Yeah. And, from classical, what they would consider to be classical osteopathy, to more of a traditional osteopathy that's taught at the BSO. There's lots and lots of different things. Lots of, like, you have, 5-year cranial, vastly different. When I came back to Australia, I had the experience of, I'd been teaching at the time, and when I came back, I had the experience of being shut down a little bit here by osteopaths in Australia here. And I felt like the association at that point in time didn't really represent, or didn't represent me, didn't represent the clinic that I was opening. Like I was looking at an employee model, and the insurances, they didn't have a way of helping with the insurance through that. So it was all, the costs were too high, and then other things happened during other points in time that I just didn't agree with.
Right. So what were you shut down? You said you were shut down over some things. What were those things?
So one of the things that's quite interesting about osteopaths, like, well, I shouldn't say all osteopaths, but we're relatively closed to, there's always a lot of confrontation around a new osteopathic idea. What is osteopathy? Like, this is, it comes back to what is that? Because we don't define ourselves very well. It's like there's always resistance around the thing. Does that make sense? Like,
Yep.
well, that's not my osteopathy. Yeah. So I can see why the association has so much trouble. I can definitely see why it's problematic for them. And as a community, I think we have to do better. And I don't know how we do that. I don't know how we come together more as a community, because I know the OA is trying hard. I understand that. But again, I think, without having a good definition for us to join, it makes it difficult, right? Because what your beliefs are and what my beliefs are could be very different in what the OA has to push.
Yeah.
Does that make sense? Yeah.
Yeah.
And until we make these group for a democratic society, but we have to make a group decision on what this thing is.
It's mob rule, which doesn't really work. Yeah.
Correct.
Okay. And what were some of the other things? You said there were some other things that you didn't agree with.
So I think that, I think there should be a place for osteopaths to have open discussion.
Right.
Yep.
I agree.
And I think that
this is why I've got this platform.
Yeah, and which is brilliant. It's like one of the only places that you can have the open discussion.
Yeah.
And I think the OA should be responsible for holding that open discussion, and no things should get closed down.
Yeah, I agree totally, 100%.
So I think that's what a board should be doing for, they should be doing for us.
So you don't feel that open discussion is encouraged?
No, I don't. I don't think I don't think it's as free as it should be. No.
Right. Okay. Do you have any specific examples you want to share with us, or nothing that
No,
comes
not
to
so
memory?
much, but I just think that, so there's definitely, I don't think it's the board's fault. Let's come back again. Let's come back to so I was kindly invited along to that meeting by a friend of mine, Heath Williams. Yeah.
Shout out to Heath.
Yeah, he's a legend. And it was great to go to, because I got to sit. So what was really interesting that I found is that I think there was maybe 30 people in the room, and more power to them. All the VU academics and RMIT academics were there. Yep. Amazing. That's like, they're giving up their Friday night to for the future of osteopathy. What was disappointing was, and I'm as guilty as the rest of all the clinicians out there, the bulk of what osteopaths make up, which I assume is just clinicians working.
Yeah.
I assume that's the majority, weren't there. Yeah. So how do we get input if we don't turn up and talk?
Yeah, definitely. I agree. I think, yeah.
Because the town hall meeting is the one place it can be done. Now, I know a lot of people, because I'm not an OA member, I wouldn't have known about it. Yeah. But like I said, thanks to Heath, I went down, and when I listened to the what they're doing, there's some things I think are brilliant. So yes, next year I will probably sign back up again.
Right. Okay.
There's some things they're doing I don't like.
Right. Yep. Okay. So what is it that you do like about what they're doing, and what is it that you don't like?
Oh, look, they're pushing hard for to help us with different government policies and that sort of stuff. They're working tirelessly on that. And I'm in a interesting position where because I'm friends with Heath, I see how hard, he's not paid, and I don't know how he finds the time. The guy's he's just a machine. It's just unbelievable. So they're serving osteopathy in a lot of unbelievable ways. But then I think because their clinicians aren't turning up to say what we need and to say what we think is happening, the direction is pushed by the people who do turn up. How's that sound?
Yeah, I agree with you. Where I would probably push back on that a little bit is that we really need to understand why they're not turning up. Do you think that there's a lack of passion and love for what they do? I don't think that's the case. I think, and one of the things that I really admire about what Heath is doing is he wants to re-engage with
Correct.
former members and current members. And most of those people will be clinicians, right? You need to ask them why they're not engaged. It's not, people don't just disengage for no reason. Like, there's usually reasons why people stop turning up to things. And I guess we need to find out why. Again, we can't blame the patient. We got to look inwards. Why clinicians not turning up? Okay, maybe most of them have family commitments and so forth and X, Y, Z, but there should be at least 10 or 20 that could make it out of the 2,000 or so members. I mean, that's across Australia, but maybe the 900 or 1,000 members that are in Victoria, there should be at least 10 or 20 private practice clinicians that can turn up. But I think
Agreed.
also there was a few there. I saw some photos about the Melbourne one. Angie Bruce comes to mind. She was there, I think, and Bruce Duncan was there. They're in
There's certainly a
clinic.
few. Yeah, I get it. But
They're in clinic. They might be teaching as well, but they're in clinic as well.
I get it. But we need the people that aren't in the universities.
Yeah, fair enough.
Because this is what I mean by the voices aren't heard. Like, these are the voices that aren't heard. Yeah. Like the osteopaths, I think so. Osteopaths tend to be so humble. Yeah. Like, we have some big voices, don't get me wrong, like that really like to shout. And I seem to like to get my opinion out there. Otherwise I wouldn't be talking to you and stuff as
That's
well.
all right. I chase people down for this, mate.
Yeah, but we really need just the osteos who are just loving the job, doing it day in and day out.
Yeah.
To get in here and say what we need and how things need to change. And I mean, you've been a big voice for getting more people up to Sydney and that sort of stuff. And I think that Melbourne is saturated.
Yeah, it's maybe a little bit saturated, but I think there's also a little bubbles forming around osteopathy, and that bubble is probably Melbourne.
Correct.
We don't have any board members from New South Wales at the moment. All board members and we're not looking at that when we vote. People who are voting aren't looking for that. And I guess I get it. If you're in Victoria, you don't care what's happening in New South Wales.
No, I don't know that's true.
You're not going to care. You're going to look at the issues that you're facing, right?
Correct.
We're facing different issues at the moment.
Agreed.
And you're going to care about the issues that you're facing. I'm not saying you don't care. I'm sorry, I should rephrase it. You're going to care more about the issues you're facing. And I guess the people that speak to those issues are going to get your vote.
Yeah. But I think, some of the things that could be solved would be solved together. Does that make sense?
Yeah, 100%. Yeah, 100%. Definitely the profession needs to be a national profession. And so, yeah, I mean, that's another topic of conversation that we can go down a rabbit hole in. But
it's a big rabbit hole, because I do think we need to push on that as well, because I think that not just we need to be national, I think we need to be international.
Yeah, no, I mean, yeah, I guess so.
Like the UK, like we New Zealand, like we need some way of
having an alliance.
Correct. So we can come to this idea of what we are.
Yeah, well, let's get our own house in order first, I think, before we try to fix other people's homes.
Oh, but I mean in terms of what we are, in terms of so we can sell who osteopathy is.
Yeah, but I mean, like, I'll give you an example. Speaking to Raymond Perrin, I asked him this same question, and he was talking to some of the I think what's that regulatory, the General Council, JOSC. And they asked him, about the scope of practice. Government regulators, the NHS, people like that were asking about scope of practice for osteopaths. He said, there is no scope of practice. What are you talking about?
Yeah, of course. Yes. Yeah, because that's the thing they can get away with.
Yeah, he goes, what are you talking about? There shouldn't be a scope of practice. We don't just do neuromusculoskeletal. We work on a whole bunch of different things. It's a system of medicine. There's no scope of practice that we recommend. And so, that's going to be difficult. And I think we just need to get our own house in order. And then we can if we can you get your own house in order, and then you have a conference and you put your own views forward. And if we can come to an agreement with the UK, the Americans, the Europeans on some framework for osteopathy. And I think all osteopaths, whichever way you practice, I think we can agree on the principles. That's where we're going to start. But this is a whole other area that we can really go deep diving into.
I think.
Yeah, go ahead.
Well, I just think that that's the place that we should start, is agreeing on the principles.
We need to agree on that. I guess, yeah, you're right. And this is one of the things that I've been critical about with Osteopathy Australia. And I've got to be careful, because if I got to also talk to that. I'm not criticizing the effort of people who work at Osteopathy Australia. Let me make this thing one clear. You know, if you're working on government policy, if you're working on NDIS or whatever it is, I may not be happy with the outcome of what's going on, but I'm not, I'm not criticizing the effort. I'm sure everybody turns up to work and does an honest day's work and puts in probably more than what's expected of them. And so in terms of effort, you know, A plus. In terms of outcome, I hold different views on other people in terms of what we've actually been able to achieve. And so, I think that, but that's, you know, if you're being critical, that's where, you know, you can't, I'm criticizing outcome. And so one of the criticisms I've had is that we haven't been able to have a position statement on anything. I just went on the Chiropractic website, and they had a position statement on the whole process, you know, the whole thing of COVID. During COVID, they put out a position statement. I don't think we did that. I don't remember doing it. I could be wrong. If I'm wrong, please correct me. Somebody please correct me. But I don't think we put a position statement on that. As for it, I'd love to hear why. And so, but that's a controversial thing. I get it. But a lot of osteopaths were alienated during that time because osteopaths have varying views on, I guess, vaccines, on and obviously, because we're regulated, we need to support the national health, the national policy on vaccines. I don't disagree with that. But in saying that, there is a way that you can support a policy and ask that that policy is continually being reviewed and looked at and made sure that it's better. And so there's nothing wrong with that. But I guess we need a position statement on who we are and what we do. We haven't attempted, that's a large project. It is a large project. We haven't attempted that. And that's one of my criticisms. I don't know whose decision that is to make. Is that a staff decision? Is that somebody in the staff? Does the CEO kind of put their hand up and say, I have an idea? Does the board come up with that? Does the board get together and say, hey, you know, this should be part of our strategic plan? And I hear a lot about strategic planning, and that would have been one of the things I think they would have discussed at the town halls, their strategic plan. From what I understand, the board is responsible for putting together a strategic plan, and then the executive is responsible for executing on that. And so if it is the board, then we need to have some people on the board who are brave and who are ambitious enough and want to punch up and say, hey, we need to get our act together in defining who we are and what we do and where our place is in the marketplace of health in Australia. I think personally we're in a very special place. Like, I think we need to put ourselves up there in a very special place. But we need to define that. We need to get together a profession and define that. And how you do that, I'm not the smartest person in the room. I have ideas, but I'm sure that, you know, we got to get some people in there together. And we've had these challenges before in our profession. We've been fractured. You know, was the Australian Osteopathic Association down in Melbourne. There was the Pacific something or other over here in Sydney. I think there was a whole bunch of different colleges here, and they all had their own and they all finally got together. And if you speak to Wael Mahmood, he'll tell you the story about how they were all able to get together and form the Australian Osteopathic Association as one voice for osteopaths in Australia. And they all had different views on osteopathy, and there was a lot of dissent at that time. He'll tell you there was a lot of dissent from very experienced, well-to-do osteopaths on that particular process, but yet they were still able to do it. And here we are, you know, 30 years later or whatever it is. You know, that was in the 90s or the 80s, 40 years later. And so it is big and bold and brave, but it is, you're right, it's a necessary step before we can really tackle a lot of the bigger issues. And before we become monochrome, we need to take that step.
Yeah, and look, we need to decide, like, if that is because, you know, like I said, we all have our opinions on what osteopathy is, like, and so the more voices that we get, the more that we can get an idea of the thing that the majority want it to be.
So,
does that make sense?
Yeah, based on my conversations with people, I ask this question to a lot of practitioners that I talk to, and I'll ask you that question in a second. But when I ask people what they think an osteopath is, all of them generally come to the same answer about principles. Very, very few. And if some of them kind of beat around the bush a little bit, they eventually get there. And so I don't think there's actually a lot of argument around what osteopathy is. I think there's a lot of dissent on how osteopathy is practiced.
Perhaps, but I do think that some people think so. So the principle, like,
You got your cranials, you got your structurals, you got your biodynamics, you got the movement guys, you've got the whatever. Like, there's a whole bunch of different ways. You got people who combine things, people that think that, and there's nothing wrong with all of those approaches. They're all tools. I don't think we should argue about the tools. This isn't it's not what this is about. Getting together and having a statement on who we are and what we do, or who we are and what our identity is not us having a debate about the tools that we use. It's about having a debate about our philosophy, our practice, our approach,
Yeah.
I think there's more there that unifies us than that divides us.
I think so as well.
Yeah. Yeah. Okay. Well, I guess I want to take you back to that town hall that you had that Heath so kindly invited you to, because he's a champion bloke, mate. What did you ask? Tell us. Like, what did you think of that? Like, what did you get out of it? I know you said that they were doing some things in their strategic plan. What were some things that you liked? I guess what were some things that you didn't like, and what questions did you ask?
So there's lots of things that I liked. I think that
you covered a fair few of those.
They have come up with a strategic plan to
more government kind of talking to government and lobbying and policy and all that kind of stuff. Correct. You mentioned that. What were some things that you kind of said, you could probably spend your resources better?
I'm going to sound like a broken record, but like like you, Sammy, I think that the principles are what makes osteopathy. Yeah. I think, we're an art and a science. Here we're a manual medicine, and we base it on the 4 principles.
Yeah.
Now, I think that there's individuals who do not think that the principles are important in defining us.
Right.
And I don't agree with that. I think that we need to, as we've already discussed, figure out what we are, and we need to do that before we do some other things. And what I mean by that is, creating a sports osteopath and a pain osteopath and all that sort of stuff. I think that just adds confusion to the mix until we know what we are.
Yeah. I'll ask you about the titling in a minute. I want to ask you a question on what you just said. You said that you think there are individuals who don't quite agree that the principles are overly important. I'm not going to ask you for any names that, you're not going to tell me, but I will ask you, do you think that those individuals have, I guess, any influence over policy?
Well, I don't know, because this is the first. So let me, I'm going to put my hand up here, right? I am so guilty in sitting back and doing nothing. It isn't funny.
Okay.
Yeah. I've just been in my little clinic doing my thing, teaching, but ignoring the world. Does that make sense? Yeah. Especially the political world. And I still want to ignore the political world. It's not me. I don't like, I don't like policy and all that sort of thing. I don't even enjoy the conversations around it, but I'm proud of the thing that I am. Yeah. And I would like osteopathy to move forward and not move forward in the shadow of something else. Does that make sense? I feel like we chase our tails a lot because we're not proud of ourselves. Does that make sense? Like, we want recognition because this group has recognition, or because that group has recognition. Well, I don't care.
Yeah.
I want to be able to go to work and do my job, and people know what I am, and I can refer to an osteopath anywhere and they're going to be good.
Yeah, I agree.
That's it. Like we talked about Heath before. Heath is an amazing character who really is. I have no organizational ability. Yeah. I can barely run a diary. Yeah. It's just, my mind is haphazard. It's not the way that my brain works. I'm not structured in those sort of things. And we need people within the organization that are that way, that are very driven, that are charismatic, that can do all those things for us. And you talk about, he's going out and making phone calls and lots of stuff, trying to find what the people want. Well, I would like it. And what he showed me is the people need to go to them. Does that make sense? We need to get in there and tell our point of view and how the principles help us practice. Because there would be people who would say that the principles don't matter because no one can articulate properly how it helps them within a day-to-day clinical encounter. Yeah. Now, one of the difficulties is, because I will say this, so within my practice, the principles work as memes.
Okay.
So they're things that I can contain a wealth of information of the skill set that I've developed that help me think through a patient, but they're my memes. Yeah. So I have added those principles while we all share them. The way I have thought about them helps me with my patient base, and the way other people have thought about them will help them with their patient base. And they can be slightly different in the way they utilize those things. And that's why we practice differently.
Yeah.
Yeah. I have more principles than just the 4, as probably you do. You probably have other things that you go to when you're treating a patient and you're stuck. Yeah. And they're just little bits of information that contain things for us that we can work with. Yeah. It's very hard to work with models. Like a principle is easy to work with, that your brain would blow off if you could think of all those things at once.
Yeah.
Does that make, yeah. Yep. So there, and I'm not saying the biopsychosphere is bad, please. Like, it's a thing that you can go away and work with, a theory that can help you understand patients better. I get it. Yes. We can be away from the patient doing that, but in front of the patient, you need quick things that trigger you. Yeah. Yeah. So that's how they work for me. Yep. And that can be different for how they work for someone else. And that's the art. Yeah. That's the skill that you develop yourself in the way that you manage the patients. Yeah. Yeah.
Yeah.
I don't know.
No, I get it. I get it. Yeah, you are making sense in what you've said. I want to just take you back though to, I guess, the question that I asked you. Do you think that, I guess, the people that don't think that art is important, the principles and the philosophy, and I guess your individual right to practice that art, and because the way you said to me that, the way you apply them is maybe a little bit different the way I apply them. Do you think the people that feel that art is not really any important in terms of defining our profession?
Correct. I think this comes back to your monochromatic practitioner.
Yeah, but do you think that those people have influence over policy? Are they people who, are they people who are in positions of power or able to shape?
They're in places that can do particular things. Yeah.
Are they in universities? Are they in boards?
Yeah.
Are they in associations? Are they,
I think they're definitely in both. Because this is what I want to, I think that they're needed and they're in both.
Yeah.
And I think that we just need to be expressing, because my personality type is not organized.
Yeah.
And I think a lot of osteopaths are that way. I really believe
I'm all for those people being vocal about what they think. If they think that those things aren't important for osteopathy, I want to hear it. I'm actually vocal. I want to hear it because I've got pushback against it, and this is the dialogue that we need to have, right? And
Agreed.
So this is the dialogue. The problem arises is when there's no dialogue, and then we can't have this conversation and we can't get to a final endpoint. And whether that is because what you're saying, a lot of the people who are in clinical practice just don't put their hand up to come forward and have a chat, or whether it's because when they do have a chat, they get shut down, right? That's another point. And the third point I wanted to make is that a lot of members speak with their membership. A lot of members, I mean, like yourself or whatever, but I know a lot of people who were members for years, 20, 30 years, and now aren't.
Yeah.
Those people I've had on the podcast. Yeah, John Smart was one of them. I studied with him, and he said on the podcast plainly, I was a member. I'm not a member anymore. They've spoken with their membership. And so that's the biggest vote for me, that you've done something that osteopaths aren't happy with. And so in that case, when you've been a member for, 5, 10, 15, 20 years, and you've given somebody, your money, your hard-earned money to be a member, and then all of a sudden you decide this is not for me, I don't think then the onus is on the person who's stopped their membership to call up the association and say, hey, this is the reason why I'm not rejoining. I think the onus then is on the association to give them a call and say, mate, you've been with us for 20 years. What have we done? Like, is there anything we can do to, it's like you've got patients, Matt, that you, for many, many years, 15 years, 10, 15, 20 years, they were very loyal and probably see you whenever. And say you don't see them for a while, as a practice, you think, I'm going to put a phone call and just see how they're going. You don't wait for them to call you and say, Matt, mate, you came in one day not wearing deodorant, you stunk the place out, and that's why I haven't come back. Whatever,
Yes.
You pick up the phone and you say, hey, John, how you going, buddy? Just checking on you. I haven't seen you in 6 months or a year or whatever it is. Everything okay? Is there anything we can do for you? Oh, yeah, mate, everything's fine. It's just, last time I was there and something happened with the FPOS machine and they wouldn't take my health fund, and I was a bit flustered and I got a bit pissed off, and sorry, you know, I was just a bad mood that day and I just haven't made an appointment. You go, okay, well, whatever. You make that connection again. You know what I mean? It might be something really little, or it might be something big that you can address. At least it gives you an idea of where you've gone wrong. Heath is the first person I know that's done that. No, Heath's the first person I know that's done that. The first board member, at least anyway. I could be wrong. I just don't know. He's the first person that I know that has done that. And so they're the three things that you really need to look at in association, is that, you know, clinicians need to come forward. Then they need to have a space where they can be heard and a conversation that doesn't get shut down. And then also when association members speak with their membership, that also needs to be investigated and seen why people aren't rejoining. It seems like that they're currently doing it for new graduates. Like, there seems like Osteopathy Australia is interested as in why new graduates aren't taking up that membership, or early career osteopaths. That probably has more to do with finances than anything else. But I'd be more concerned if a member that's been with you for 10 years decides to not renew. That would be more concerning for me. But anyway, I want to ask you, unless you have more to add to that, but
well, I was just gonna say to that point, like, I don't know, like I said, I'm not politically minded. It's not something like I'm in practice every day.
It's not a question of politics. It's a question of just understanding how to have conversations and how to actually get to the core of what people require, whether it's an association, whether it's a university, whether it's you're an academic or a clinician. We need to have open dialogue and conversation.
Oh no, I agree with that. What I mean is, like, but if we want a voice, if we cut ourselves off, I guess this is the one thing that. So one of the things that Heath has opened my eyes to. If we cut ourselves off from the OA, what voice do we have moving forward? Like, yes, you're making a point to the Osteopathic Association that they're not doing the thing that you want them to do, but without them, we have no voice. Or well, maybe you've got a voice now because you're a little bit like Joe Rogan, but of the osteo world. But
you know what? He keeps calling me up, mate. I've got to let his phone just ring out. He keeps wanting me to, you know, I don't have time to get on his podcast. He's got this tiny little podcast, and he keeps calling me and saying, you know, mate, you've done Success in Practice. Can we get you on the Rogan Experience? I don't have time in the day between this and running the clinics. I don't know. Anyway, look, back to your point.
Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy, and back to the show.
Back to your point, I understand that. I don't totally agree with it. I think there comes a point where if the system isn't serving its members in, I guess, a way that, I mean, look, last I checked, the last election results I saw, there was 2,009 voting members from what I understand. And so unless I'm mistaken and I'm off by maybe tens of votes, it seems like there's 2,009 members that are signed up to Osteopathy Australia. Now, not all of those members will be paying members. Some of them might be life members or whatever it is. You know, I think the profession sits around the 4,000 mark at the moment, just over 4,000, which makes us 50% representation.
Yes.
We're a small profession. We can't afford to have that percentage representation, right? And I'm not saying that I'm encouraging this, but very easily, I think you can get a coalition of probably 400 or 500 osteopaths that could start their own association in the next 6 months and come to an agreement on a different direction that they'd like to take. I'm not saying that I'm just putting something out there that's a total hypothetical, but that's the last thing that we'd want. Right. But there are, there would be people that might think, oh, well, I'd rather be part of something that truly represents me or be part of nothing at all. You know, I get that point of view. Where do we draw the line? Where do we say, okay, this isn't really representing me. You're not representing me. I need to find something else, do something else, or just not be part of anything. I don't have answers to that question. I don't know if that's great. I just don't know if that's great. 2,000 members in a profession that's probably 4,000 or 5,000 strong. I don't know if that's great representation. I'd like it to be around the 60 or 70% mark. I don't know what other associations are like, what a physiotherapist like. But here's the thing, right? You don't need a lot of members to be the peak body. I mean, physiotherapy, I think, is sitting around 30,000 physiotherapists in the country. They could easily have 10,000, for example, members in their association, and that would be a very effective association. And that's 30%. But we don't have that luxury. We don't have 30,000 members. We've got 5,000 members, which means we've only got 2,000, we've got 5,000 or between 4 and 5,000 osteopaths. We need more than 2,000 members in an association and to be able to call it the peak body that truly represents osteopathy. And if this big, bold plan that me and you were talking about is ever come to a fruition, we need more than half the profession to back it, And so, it's interesting, and there's room for growth there. I think that's the positive out of this. I mean, there's room for growth for the association, for Osteopathy Australia. There's room for growth for people like Heath to come in and help re-engage members. I think if we can get, if they can re-engage at least another, 4 or 5% every year, I think very soon it'll be an organisation that truly represents the broad spectrum of osteopaths across the country.
I think that if more osteopaths could turn up to that town hall meeting, like it's once a year, and just see what's being said, let the board members tell people what they're doing, so you can make a informed decision. That would be a good step forward. So that my plea would be next year, at least in Melbourne, even if you're not a member. Get in there and listen, and then make an informed decision.
I was hoping they would do an online one. I was hoping, and they said that they would, and I haven't seen anything put out for that. I was hoping they would do an online forum, and I think that would be a good thing because I think it would remove a lot of barriers for people. I know the Sydney one was scheduled at like 7 p.m. on a Tuesday night. I usually record at 8 p.m. So on a Tuesday night. I think it was a Tuesday or Wednesday or something. I can't remember, but that's just a tough time for me with family, even when I'm not recording. And that's all it came down to. There were some other personal reasons, but I'll go into those another time. I want to ask you then, whilst we're talking about Osteopathy Australia, there is, you touched on it earlier about the titling that's available now through Osteopathy Australia to be an advanced practitioner in sports, in pain, I think there's one in rehab, there's one in occupational rehabilitation and therapy. What are your comments on that? How do you feel about that? How do you feel about someone having an advanced title? And then secondary to that question, is it fair that only Osteopathy Australia members can have access to that?
Look, that would be one of the things that I probably liked least about the evening.
Okay.
Yeah, I don't like, so an osteopath is an osteopath. That's what I've got to say about that. Like, I don't think we need, like, I get it. I totally understand that people can devote years to studying pediatrics.
Yeah.
Or whatever they want to study towards.
Yeah.
And their patient base will reflect that.
Yeah.
Yeah. Like, I don't see kids. I won't, like, I don't know enough about young children. So it's not the focus of my practice. I'm a generalist.
Yeah.
I see elite athletes. I go off on camps with elite athletes. I also treat
everyday people. Yeah.
40% of my population is geriatric.
Yeah.
And then I have some chronic pain patients.
Yeah.
Yeah. I rarely ever see because of my style of practice, acute patients are rare.
Yeah, right.
Yeah, yeah. So it's not that I don't see them; they're just rare in my practice.
Okay.
Because of the way I go about things and that sort of stuff, and that's I use osteopathic principles and do osteopathic stuff.
Yeah.
And that's how I feel about that.
There's no real title for you.
I don't want I know
you don't want it. I know you don't want it. I know that. Yeah.
I don't even really like I don't even like the doctor title.
Yeah. Right.
Yeah, like I'm an osteopath.
Yeah.
That says everything I do.
Yeah, I get it. I understand. Well, okay. So do you think then it's a problem that, I mean, part of the problem, and I talked to Bruce Duncan about this, is that, what we don't want to see is, people who are, barely 2 or 3 years out of uni go and do a master's degree and then, end up being an advanced sports osteopath.
Yeah.
And they've barely practiced, they've barely seen, 100 people in the clinic. And so that's a problem. he's saying now that they're looking at making that at least a 5-year process, putting some barriers around that, which is a good thing. So that's the problem I have with it. I not necessarily. I mean, I know that there are people that see some niches and types of, and that you're right, their patient base will reflect that. My question to those people is that why do you need the title? Like, I'm really interested in what the need for that title. Is it a recognition thing? Do you want to put it on your business card? And I'm asking this I'm not asking it maliciously. I'm not asking it in a disrespectful way. I wonder why. Like, I'm just interested in, is it just that they're recognized for the kind of work that they do? And so, yeah, it'll be interesting to hear from somebody who is titled why that's important.
I mean, I can appreciate the effort that they go to. Like, I'm not talking about those things, but I like, as in terms of like people, there's osteopaths out there who have spent their careers focusing on a particular element of osteopathy. And I suppose that they want recognition.
Well, it's not a particular element of osteopathy. It's a particular element of the market.
The market, yes.
Right?
Yes.
And so, osteopathy is osteopathy and the market is the market. So, you've spent your whole time targeting athletes. You spent your whole time treating people in chronic pain. You spent your whole, whatever, but you're targeting the market. And so, yeah, that's probably how I would put it. Yeah. I don't know. Bruce mentioned, because Bruce Duncan was one of the people that was kind of championing this at Osteopathy Australia, and he helped with the setup of it. And he mentioned that, that other professions do it and they kind of leverage off that. And I guess, I don't know, I'm not somebody who likes to care about what other professions do. Like, I don't know. I'm bewildered. I need an answer to this. Like, what's the reason for it? I want a valid reason. I mean, if you tell me that physios do it and chiropractors do it, there are sports chiropractors out there and osteopaths want to be able to have a title. Okay. I'll take that as an answer, but I just think that I think that's a weak position.
Yeah. So, because that's the position that worries me as well. So
why does it worry you?
So
elaborate on that for me.
Okay. So I had the privilege of working at Pure Sports Medicine in London. Now, you probably don't know what that is, but it is was one of the most premier sports physiotherapy clinics in London. It was one of the first of its kind in terms of having sports meds and physiotherapists working in basically the one center. And I was lucky enough to be the only osteopath there. Now, there were great physiotherapists in that clinic, and I was there at the time of the London Olympics. And because of that bronze gold scheme that they have, there was physiotherapists who had worked with particular sporting groups for 5 years, and then it comes Olympic time and they get kicked out because they're not gold in their association. They're only silver in their association. Right. Yeah, but they're the ones who've done all the hard work leading into that thing. Yep. And so that might be, people might say, well, that doesn't have to happen within our osteopathic setup of this particular thing, which is true. But the likelihood of those sort of things happening, like you're putting these things in place for a reason. Yeah. Does that make sense? Yeah. To one up somebody else. And what's the reason on that? So,
I think it also gives credibility sometimes where there needs to be some more scrutiny. Like, I see people teaching courses who market themselves as dual title sports, rehab, whatever it is you want to do. And I'll look at what they're teaching and I'm like, really, this is what you've thought about something, and so, I've got to be, I think, we tend to attract the people that we do really good work with, and the market should be the place the market should decide who they see. I think and some osteopaths, like, I'll talk to Angie Bruce about this, and she said that she's mentioned that it's a really good thing for patients to have because it can lead them on to people who are more specialized in the type of care that they want. But I guess you'd find that out pretty quick from doing your own research on osteopaths. And I don't know if the training at the moment is that rigorous that would really qualify why somebody might want to see you. For me, the jury's out. I'm not totally convinced. I'm not totally against it, but I'm not totally convinced. I have my reservations on it. I, like you, in essence, believe an osteopath is an osteopath. There are some things that I just would come to see me. I could talk to you about pain, like chronic pain. I treat a lot of it, and so I would be well positioned to talk to you about that and talk to somebody who has an advanced title and put myself in the mix to treat somebody with chronic pain. I could easily, I've been doing sports medicine for my entire career, so I can easily kind of talk to somebody who has an advanced title in that field. If there's like any, if there's a pelvic health or some kind of women's health or advanced pediatrics is one I think that's there. I could in principle talk to you about pediatrics. I just don't see a lot of it. I don't ask for it in my clinic. If I see the odd, 6 or 7-year-old, it's because I treat the parents, and I have a quick look. But in principle, I can have a conversation with you about it. I could talk to you about, fluid flow and dynamics and movement and the importance of, development, the gait cycle, the neurology of that child that's still expanding. I can have those conversations with you. I just don't see enough of it. I would rather just pass it on to somebody else. But being an osteopath, I could still have enough there to talk to you about it. You could too.
Agreed.
We talked about this earlier where you don't encourage a lot of that. You don't encourage seeing children in your clinic, but it doesn't mean that you can't have a conversation about it, that you can't have an opinion on it, or that you're somehow less qualified to direct a patient in what they can or can't do.
And I think when you know someone's good at something, so look, if I was talking about my practice, TMJ is, again, it's not a strong area of my practice. There is a brilliant osteopath, Fontaine, just around the corner from me, who loves TMJ. I'm like, she doesn't need a TMJ title. I'm like, get over there, go see her. I've got Meg up the road is unbelievable at pelvic floor women's health. I'm like, this is a little bit of my scope. Go over there. Doesn't need a title. They're just, and they refer to me. They're like, you need some movement. Matt, it's good at that side of it. Get over and see Matt. Good.
Yeah, no, couldn't agree. Couldn't agree more.
I think we have bigger issues. How's that sound?
Yeah, definitely there. I think you've hit the nail on the head there. I think there are bigger fish to fry, but I think that ball is kind of that ball is rolled and it's getting a snowball effect as well. So I don't know if that can be, and I don't know if I care enough to stop it, but I think definitely it's just going to keep growing. The advanced titling is something that's going to continue to grow. I think, especially amongst graduates who feel like that is something that might give them a bit of an edge, where they might not have osteopathy as the edge that they come out with at university. And I guess the last thing I want to talk to you about, and we've talked to this earlier in the recording tonight in our show, we talked about getting to some kind of position statement on who we are and I guess what we believe in. And instead of asking you what that actually is, I want to actually ask your opinion on, I think we have, you answered the question earlier, but I want you to elaborate on it. Do you think that that's an achievable task? Do you think that we have more in common, more that unites us than more than divides us? Do you think that's something that's achievable that we can do?
Well, I think we need to do it. Like, when coming back to, are we going to end up as a homogenous beast of myotherapy blended into whatever it is? If we don't, I think that will happen in the long run.
Okay, so it needs to happen.
I think it has to. I do think it needs to happen.
Yeah,
and I think it needs to happen sooner rather than later, so the education system can perhaps direct where we're moving forward to.
Yeah,
I think it was Tom you had on your. Was it Tom that you had on your podcast that when you were going through the delegates?
Tom Barry.
Yeah, I really like Tom, and Tom's
was a good guy.
Yeah, he actually, I'm gonna feel like reaching out to him and having a beer because I really enjoyed.
He came across to me like somebody I could go and have a beer with. So
yes, he does.
Shout out to you, Tom.
So maybe when he comes down to video, I'll be able to pin him down. And anyway, he was talking about leaning into our hand skills, and I fully agree. Like for the future of osteopathy, I think that's something that we. My practice is a movement-based practice, but it still relies heavily on my hands in terms of helping guide movement and doing different things. Does that make sense?
Yeah.
And I think that given where the future is heading with AI, you can already get like one of my other osteo friends were talking about. You can already get a pocket physio, right? Which is basically these are the exercises that you do.
Yeah.
Yeah, and that pocket physio AI is with you all day, and it'll beep you and say you haven't done your exercises and that sort of stuff. Yeah. So one of the things that is really going to be defining for us is our touch.
Yeah.
That is going to be something that's going to be, for our future, I think is going to be needed. Does that make sense?
Yeah, it makes sense. Totally. So here's the thing, right? And this is where the disconnect sometimes happens between what you, the professional, me, the professional, and every osteopath I've had on this show has said that, hands-on. I just, this Monday, well, we're recording this. And so the episode that I'm about to air is with Charles Beck. Charles is a osteopath, excuse me, an osteopath in America who is probably about, I think, 2 osteopaths displaced from AT still. And I asked him what osteopathy was, and he said, well, one of the things that defines it is our hands-on approach. And that's something that every osteopath that I've ever talked to can agree on. The disconnect happens is when I see, for example, that maybe I can be corrected, but I should have, it's hard for me to do research on the spot. But they had, I think, some kind of officer over at Osteopathy Australia who was promoting hands-off osteopathy or practiced in a hands-off fashion and wanted to promote hands-off approaches to osteopathy, whether that be telehealth or whatever it is. Now, I get it that some people want to go in that direction, but that's not something that we need to pull resources into. I don't think it is, right? So that's a criticism of performance and outcome. I'm not criticizing that person who's there because she's there for a reason, and she's there to do a job. But I just don't think that is required. It's not a criticism of her as a person. It's a criticism of for the decision that gave her that particular role. And so this then begs the disconnect between maybe what's happening in policy and what the practitioners are talking about. Yeah. Do you agree with that? Do you see?
Yeah, I do. I think that there's like hands-on somewhere in the last couple of years, it became a little bit dirty.
Yeah.
Yeah, it's strangely, it's like, and
well, we heard it in we saw it in the recent registration survey. How many hours of telehealth do you practice a week? 0?
Yeah.
I mean, I get on the phone and I have a chat to the patient.
Yes. Yeah.
I don't charge them for it, but I get on the phone and have a chat to them. 0. What are you expecting to hear? Even if you are expecting to, but I mean, that's a survey through AHPRA. It's not really, I guess it's not the association that's doing that. Yeah, we need to double down on that. The hands-on stuff needs to be doubled down on.
Yeah, I think that's really important. And I this is what I was coming back to before. Like, no matter, like, the biopsychosocial is exceptionally important. The social aspects are like, we know that we missed a huge chunk of particular things in the way that we treated patients previously.
Purely biological, you mean?
So no, yes, yes, correct.
Yes.
When we were correct, and whenever a new model comes in, I think there's always too big a swing away, and you have to come back. Does that make sense?
Yeah.
And I think that's what we did. We went too far away. We followed some other instead of being osteopaths, I think we followed other therapies. I think we, in particular, at least their evidence a little bit too tightly, and we stepped back too far from the thing that we did very well. That was always what gave us the market edge.
Yeah. Yeah, you're right. And now hopefully there's a swing back, and we need to talk about that.
And that's it. And so that's the thing. So we need to come back to that balance point, not to go back to where we were, but be in a better position and get that position back.
Yeah, and I think a lot of people would agree with you. So based on that, I think we can get to some kind of consensus on things we can agree on. At least there are many that look. When it comes to a position statement on what we are or who we are and what we do, not so much what we do, but what we believe in, we at least should write down the things that we are united on. There might be things that we don't agree on, but we don't have to make that public. That doesn't have to be in the position. Definitely the things that unite us. We need to talk about those things.
Agreed.
Matt, unless you have something else to discuss, I think we've covered a lot of area there. We always can cover a lot of area, you and I. I think we get into it. I want to thank you for joining me tonight.
Pleasure.
Stay on the line with me, but for everyone else, thanks for listening, and I'll catch you on the next episode.